So the topic for today is, of course, this short 1 hour 45-minute presentation. Topic is gender and health. But before we go there, so within the whole theme of social epidemiology, the person that I always look up to is this guy, Michael Mermott. I think Lucy mentioned his name, and he is like the legend in this field. And I follow his work very closely, and I follow his video talks very closely. So I just this morning I noticed that this is one of the very recent talks that he gave at this Nobel Prize organization event or something. And this is just a 6 minute clip, so I listened to it and I felt like this is kind of like a recap of the lectures that you have listened in this course so far. So this is 6 minutes, very short, quick recap. And then after listening to this 6 minutes video, we move forward with specifically the angle of gender in social epidemiology theme. So is that okay to take a look at this video quickly and then move forward? Teams, if you do not hear the voice of the video, let me know. Teams, is the voice okay?
It's breaking a little bit. I think it somehow started quite well, but then it disappeared.
Okay. So let's see. Now?
No.
No, unfortunately.
It would be easier if you share the
yes, on the
link.
Teams.
I mean, write the link itself.
Yeah, I shared that also. So I have re-uploaded, but I'm also putting the link on the chat. So now if the voice does not work, just click on this link on your side. Okay?
Okay.
Okay.
So now the link is there. So we are starting. So this way both sides, classroom and Teams, are gonna catch up. Teams, have you finished watching the video? Anybody?
Yes.
Okay, should we move on? Okay, so basically, as I said in the beginning, this is putting lots of things in a very short clip of audio and video. This is to tell the idea that in every policy there should be fairness. And the concept of fairness that this guy champions, this Michael Marmot champions, is to address all these inequalities, whether they are from health point of view or other point of view within the development of different regions, from social perspective. And one component is gender. And nowadays, the discussion about the gender equalities and inequalities has gotten even more intense by increase in awareness about more sensitive issues within the gender. We are hearing, after the whole history of humans, just very recently, we started to understand the options of outside the two genders, that it is not a dichotomous issue. It is not a male and female issue anymore, but there exist other genders also that in some parts of the world are being accepted and identified bit more prominently and bit more with ease compared to the rest of the world. So this awareness about the identification, acceptance, and then bringing all those genders into this social justice system and reducing these inequalities between these genders. So this is adding much new dimension to the whole topic of social epidemiology. We were already struggling quite hard with making males and females, the two genders, equal. We are still struggling, and now we have some other identifications as genders that are also lacking, even worse than what women are lacking compared to men in almost every society of the world. So this theme of social epidemiology from the gender point of view has, in my opinion, suddenly gotten much more complex than it has ever been. On one hand, it is a really good thing that this debate has brought up new angles to us, new scenarios to us, new points for us to ponder and try to understand and do research on. But on the other hand, the issue has gotten much more complex model in front of us. So some positive, but then it shows us that much more work is needed. So today we are going to talk, of course, on this gender issue in this short presentation. Now we are here because of health. We are studying health from different angles, at least most of us. We, of course, welcome students from other subjects also outside the health theme. But this is a public health department, Faculty of Health Sciences. And in this health angle, we will see all these things. But saying that health is part of almost everything in life, when Michael Mermart says fairness in all policies, so that means that this health component should be thought about in all policies. For example, if these policies are about employment, economy, if it is about some other area of development, so no matter what the area of development it is, but health should be part of that, and only then this will be fairness concept. So if we don't think of health when we are developing policies in no matter what area, so health will get affected directly or indirectly. So that's why when the United Nations started this concept of Millennium Development Goals, and then it changed into the title Sustainable Development Goals, and the target deadline is 2030. So here in one of its goals, goal number 5, it did not mention health directly. It mentioned gender equality and empowerment of genders, all women and girls. It is not mentioning here health. But then if we look into the targets of this goal, specific points, specific targets, specific aims of this goal, it becomes very quickly very clear that all these points are interlinked. Probably Jussi Kaunen was showing you these models where lots of arrows were going in 2 directions, in 1 direction, in crisscross. So the whole concept was that all these other areas of development are also very closely linked with health, whether directly or indirectly. So what we are gonna see is that first we will see quickly the ground realities. Whenever you want to solve some problem, first you see how big is the issue, and then you plan how can we solve it. So these are some of the facts that tells us quickly that how grave the issue is. This information is taken from the United Nations webpage. It is available there today, so this is the latest statistics available. So about 750 million people, 750 million women and girls globally are married before the age of 18. 200 million women and girls in 30 countries have undergone female genital mutilation. 1 in 5 women and girls, including 19% of women and girls aged 15 to 49, have experienced physical or sexual violence by an intimate partner within the last 12 months. Huge figure. But still only 49 countries that have totally no laws to address this issue. They don't even mention it anywhere in their constitution or book of rules and laws. Only 52% of women married or in a union freely freely make their own decisions about sexual relations, contraceptive use, and health care in general. Only 52%. That's crazy. In 18 countries, husbands can legally prevent their wives from working. Legally. She cannot even challenge that in the court. In 39 countries, daughters and sons do not have equal inheritance rights, and 49 countries lack laws protecting women from domestic violence. While acknowledging that in some parts of the world, women have made important inroads into the political office, Finland, some other parts of the world probably, but Finland is, I think, leading at the top across the world, but their representation in the national parliaments, the most big policy-making institution, still stands at only 23.7%. Globally, women are just 13% of agricultural landholders. So these facts, some are directly connected to health. You can see clearly the underage marriage, the violence, the domestic violence, the sexual violence, the inability to make decisions about healthcare, inability to choose whether or not to use the contraceptive and all those related reproductive health options. These are very directly connected to health. But then there is mention of their participation in the parliament, their participation in being economically free. They are so compromised because both these things are also connecting indirectly back to health of women again. So whether it is directly or indirectly in all policies, health is there. And when health is there, gender is there as a huge issue. So Michael Mermart, that's why gives this main point again and again, that health should be part of every policy, not just health policy, but every policy. And only then the health situation can at least get better. And then looking at all these social determinants of health. Now he was talking about building back better, right? So this is the time to incorporate these social determinants of health into all policies so that when the societies are building back better, so the equality indexes and figures and facts like these start getting better. But is it realistic? Juicy was talking about the history of social epidemiology. So it has not like crazy long history, but it has at least some history. How realistic it is that these changes will actually happen or happen to an adequate or at least acceptable extent. Will we see these changes, these improvements in our lifetime? But that should not be a reason for us to stop working towards this. So we are going to be just one generation, one piece, and then the story will go on. Finland was not where Finland is today 100 years ago or at the time of its independence. So it's a slow change, but this speed is going to be different also for different societies. Some societies have already that ground layer that you can build on top of it a bit quickly. That ground layer is not that far from the ideal height of the infrastructure. But some societies, mostly conservative societies, are a bit further down, bit further away from these changes. So this pace is going to be very unequal. And Finland, where we are, so this is definitely a unique place to study this. There is this index which measures inequalities in genders. And what it does is that it picks 3 core areas of development. It picks health, it picks empowerment, it picks the labor market. And in the facts, that's why I chose these facts, that they were in all these 3 areas. There was health related facts in that slide, there was empowerment related, the parliaments seats, and then there was labor market, the agriculture, and all those facts. So these three areas were picked by this gender inequality index to compare the two genders, men and women. Again, I'm reminding you that we are talking right now only about these two genders. I will go into that a bit later. So in the health, the two indicators that they focused on is maternal mortality ratio and adolescent birth rate. In the empowerment, the two variables that they focused on is female and male population with at least secondary education. And then the other is female and male shares of parliament seats. And then in the labor market, female and male labor force participation rates. So these 5 indicators, variables they chose to compare men and women. Okay, so based on that, they reached the female reproductive health index, female empowerment index, female labor market index, and on the male side, male empowerment index and male labor workforce index. Yeah.
How is the female reproductive health index important for the female gender index? Like, why is it there? So what's the idea behind this?
Because this is one area that has been reported in research as very lacking specifically for female. So this is one area that when we go towards the specific health areas connected to male gender, first of all, the area itself does not stand out, but this area itself is unique specifically for female. And then this is the area where repeatedly from all over the world, the indicators like maternal mortality rate and connected to that child mortality rate, and then maternal, all these other health related indices throughout the process of pregnancy and delivery and pre and postnatal. So all those, so this make this woman health issue bit unique. And because it is reported to be lacking in research, so they wanted to include it because of that. So now when they compare the female gender index and male gender index, combination of these indicators, so that becomes the gender inequality index. And then the result, the higher the value, the bigger the difference between the two genders. So it is different from that previously bigger term used, the development index, the International Global Development Index. There, if the difference is smaller, so it's the other way around. So this is where the difference is bigger. So the difference between the value is bigger and the difference between the genders is bigger. So it's opposite to that. So don't confuse it. I don't know if you're familiar with that development index or not. But this is specifically where the increase in value means the bigger the difference across the genders. I show you in another ways to be more clearer. So this is the gender inequality index, the latest data from the UN website. So they looked at these 5 indicators, difference in these 5 indicators across the two genders, and then they came up with these figures. For example, if we notice Finland, so Finland has this as gender inequality index, and according to the ranking latest available is 2019, it is number 7. So if we look at number 1, Switzerland, it has 0.025 and Finland is 0.047. So the higher it is going, it is dropping in the ranking because the difference between the genders inequality increasing. So this way you can compare your countries and see that where they stand, for example, comparison to. But then specifically those 5 variables, if you take a look at, so you can see individually those 5 variables. For example, in Finland, the maternal mortality rate is here. This one, 3. And then this is the adolescent birth rate. This is the share of seats in parliament, 47%, almost equal. This is 100% the female education, but then the male is also 100% the secondary education. And then the labor force participation is 55% and men is 62%. So differences are there, but not that remarkable. But if we look at this other area, one second, it's not fun flip-flopping between these PowerPoint windows, but I'm trying. This is other information of statistics that I found specifically about Finland. So the population is roughly equal, but then within that equal, one thing that is standing out is the pay gap. In 2020, 84 cents for every €1 men earn. And then we are seeing the time spent on domestic work is about 1 hour difference. Women are spending 1 hour more than men. But then in many other areas, the difference is not huge. 47% in the parliament, very close to 50, obviously. 9.8 share of wage and salary earnings, 57% with tertiary level degrees. That's a lot. 57% of women with tertiary level degrees. I have to check what are the age. Life expectancy, they are actually doing much better than men, 84 compared to 17. Why is always women doing better in life expectancies? What is the reason? Yeah.
Yeah, I have again a question to the gender inequality index.
Yeah.
So this, what is it called? The female reproductive health index is just including women who are giving birth to a
reproductive
child.
age. Yeah. Of reproductive age. That widens up the age. So it's not necessarily the process, the actual condition of pregnancy, but it is about the reproductive age.
How can I compare them to men who are not?
Men don't have. That's why in the women, it's the only thing that is mentioned is that. But men part only, they're relying on the empowerment part of the index and the labor market part of the index. What do you suggest? What should be there?
I guess this part for me makes no sense because they're, I mean, at the end, I'm comparing women and men.
Yeah.
And to this woman, in this woman area, I'm including.
So technically, I understand what you are trying to say. Technically, it would be more equal to have men reproductive health, or if we would have included the general health of both genders as a compromise. But then this reproductive area, as I said earlier, that research is pointing out that this specific unique area is reported to be lacking.
Yeah, I understand, but it's also weird for me because
balance is not there. Balance is not there in this comparison.
No balance, and even like again the expectations that women have to get children. Yeah. And I guess this is like an idea where we don't want to be anymore. So it's like.
So this area being extra itself is an extra challenge on the woman's part. The rest of the health is, of course, the same for men and women. All those other health issues are there for both similarly, right?
Yes.
But then this specific area, and we don't have men reproductive health area to compare with.
Yeah,
that's I don't know, is it too harsh to say that men reproductive health area does not exist? But at least in the indicators like incidence, prevalence of those health issues that fall into the male reproductive health category, they don't stand out just like the women reproductive health issues stand out. So that is the reason that this is happening, that it does not feel fair in comparison. but then in reality, this area exists and the other area does not exist. And because this area is going through so many challenges socially, right, that it is affecting the rest of the health as well. Actually, in many cases, it is kind of overwhelming the rest of the health of the woman, or leading to the quality of the health of the rest of the health phenomena. So it's tricky. I understand what you said earlier and what you are saying now, but this is what is my explanation.
Yeah, even the conflict that
Yeah.
women have to get children, like
Yeah.
the expectation,
Yeah.
and on the one hand, like when we're talking about gender equality, like women don't have to get children, and in this index, I get the feeling that I have to get children to, I don't know, make this index better.
No,
so.
not children. That's the mistake you are doing. It is about reproductive health issues. It's not about having children or not having children. It's about going through the reproductive timeline that women go through, and their issues are the health care that they need without issues still are quite much more demanding than compared to the men's side, where they are almost non-existent. So now, biological things, we can't do anything, right? But then here, those biological things are making the two genders, which are social norms, socially constructive ideas. So here, those biological things are affecting the socially constructed norms of the genders. So it has to be taken into account from the social side, even though it is something very biological that we cannot change. Of course, when we talk about the equality between the genders, we have limits. That's why we never hear that we are gonna try to make the two genders equal, even in biology. That's a funny thought, right? But then they are connected still, so we cannot still ignore the biological side and its needs or challenges that connect their specific health to the social domain. So this is the finished picture among the top in global gender inequality index, GII. But then on the other hand, we have, yeah.
I have a question.
Yeah.
How the pay gap is counted?
How it is counted? So it is counted that per unit payment that you are getting. So you compare that. So for example, if you and I
understand it, but how does it count? So I do know what does it mean.
If me and our lady friend here, the girl friend here, so if we are doing the same job, and then they compare the unit earning for both of us. So unit earning means per hour. So what we are getting for the same hour, does that match or not? So here it is simply saying that their 1 hour is equal to 84 cents and ours is €1, for example. This is the simpler way of looking. It is saying basically that for every €1 we earn, they still earn 16 cents less. So again, the unit being paid is different for the two genders. And this still exists in Finland. Of course, it does not mean in every job, but it is the overall average, national average. And of course, if you are all from different countries, so if you think of scenarios from your country, situation changes. And often I'm guessing, including my country, we go further low on the rankings. Pakistan is, I don't know, 100 something. And then I was looking at what should be the example for one of the very lowest, and Afghanistan, of course, and Yemen comes to mind. So basically another event, external event, the war and conflict is what is contributing and affecting to the social social determinants of health and further draining down the ranking. So all this picture is just too many factors which are interconnected. And that is, in my opinion, its biggest challenge. Why we are not able to improve situations quickly is because they are all so interconnected. Economy is interconnected, this empowerment is interconnected, the social, society, culture, religion is interconnected. So all these things being so huge of a diagram that it makes everything to be improved in the same way, same time to have some real life effect, which is not possible, or we have not at least seen yet. I mentioned society again. So again, these social determinants of health, how they are going down or up. So the role of culture and religion also is affecting that. So seeing this picture, one can imagine the access of these women to the health services, and then specifically to the reproductive health services in a society where these practices, cultural practices and religious practices are going on. So again, the specific women health related issues again stand up and affect the whole social economic indicators. So what was, religion has this thing that what was supposed to be very progressive at one time in the starting days or early days of religion. So in my opinion, so it did not match the passing of the time. So that's why it was once progressive probably when the religions were in the early days, but now it is in the retro. Now it is kind of dragging back the societies and this, in our topic, the gender inequalities or equalities. So this is just picture. I don't want to offend anybody by saying that. I'm myself from an area that is a conservative area, very, very sensitive and emotional nature of the society and its fundamentals. A very specific religion that dominates up to 97% of the population. So I do come from the similar backgrounds. So it is still very sensitive to talk about it. I don't want to offend anybody's religion or anybody's geographical affiliation. My aunt wears the same burqa, by the way. My mother wears the black one. So now, so far, all these fancy data and facts and the talk that you have heard about the inequality, gender inequality index, I was talking about men, woman. There was no mention of those other genders that I earlier mentioned. Why? Because the data does not exist. We simply do not have adequate data. Maybe because we are not even trying to have data about those genders. Maybe that data is just brushed under the carpet, again, according to the social, cultural, and religious norms, that societies are not ready to count them, to identify and accept them, to make them visible, even in just papers and Excel sheets. So because that data is missing, so our whole very scientific subjects and our whole scientific data end up still providing us with just the male and female version. So our gender inequality index is a representation itself of gender inequality, because it is kicking out so many genders. So how can this index itself be a good representation of gender inequality? But this is the excuse that is given, is this is what we got. This is the data we got. We don't have data about other genders. looking at these things, this was all data. Looking at it from other angles, how actual life happens for two genders in real world. So there are loads of discriminatory practices in different sides. One side is mentioned here. These discriminations between the two genders start even before the birth, when there is a wish of the parents to have new coming baby to be of a certain gender. In many parts of the world, having a wish for a boy is considered better. Many parents, even the mothers, want to have boy. And the reason is connected to social epidemiology. There is a term called the social worth of the gender. So social worth of the gender for boy baby is different, much higher than the social worth of the female baby. And there is a cultural reasoning behind that why did we end up at this different worths of the two gender babies? So the timeline is that the boy baby will grow up and eventually his job is to be the earner for the family. So his socioeconomic worth is connected to his future role of the earner. So then if the parents spend a lot of time, a lot of money, lots of resources, lots of attention to the boy baby, it is all gonna contribute and make him a better earner in their hope. So it will come back to them. It's a good thing for the whole family's socioeconomic worth. But on the other hand, in many societies, the role of a girl baby is to grow up and then, as we saw in the earlier slide of the facts, maybe get married even before 18 or if not after 18 and go to a house of her husband, to another family, not contributing anything to the parents' family in the form of economy. So if the parents spend any money or resource or attention on the girl baby during her growing up, it is all eventually gonna go outside the family. They are not getting any money out of it. They are not getting much out of it in general. So the socioeconomic worth is being connected to their traditional future role according to that society. And if you see for other side, for example, Finland, parents don't connect these gender of the babies with the future earning potential of that gender, because it is roughly equal according to the statistics that we saw, very close, and hopefully will further improve. So they don't prefer in that way. So this is the very first start of discriminatory practices even before birth. Research has shown that mother's education status does have some compensatory effect on these discriminatory practices against girl children. Higher the woman's education, so girl children are relatively better protected against discrimination. It makes sense, the role of education, how it should be. So this has been seen to actually happen in reality in research. Rural-urban settings research is pointing out that rural areas tend to have much more discriminatory practices against girls compared to the urban cities, but it is not a rule, it is changing. Lately, the research in these rural-urban settings in last few decades, things have changed. Traditionally, it used to be differences across the rural and urban. But now lately, last few decades, researchers have identified that in urban areas, there can be within the urban areas some specific settings that can be even worse than the rural settings like urban slums. So how to categorize that, if we categorize that into the old-fashioned division of urban areas, it does not make sense. So now we have these further categorizations within the urban areas as well. And that has changed the rural-urban dichotomous classification in a different way. But that discrimination still exists differently in different rural, urban, or urban slum areas. Same-sex older siblings, a very, again, common sense, real-life phenomena that has been observed, that it is quite actually considered normal that if some parents have 4 daughters, then they want to have 5th boy. And if they have like 4 boys, then they want to have the 5th girl. So this has been seen as a unique situation where that socioeconomic worth-based discrimination gets overruled because they had their fill already from the boys' socioeconomic worth side for the future. Then comes all these specific situations like health practices, immunization, health, education, migrants, refugees, and all these general topics. So what I will do is that I want you to take a taste of real life dialogues so that we can identify what goes on in people's mind. We try to identify the thinking process, why they end up doing like what they are doing in their society. What is in their mind that is dictating that practice to happen, that discriminatory practice to happen like that? If women are not being allowed to freely consult the health care services, then why? So our job is eventually to offer interventions to improve the situation. And we cannot offer an implementation unless we identify these socio-cultural, religious factors that are making the people perceive things differently, making the people practice things differently. What do you see in this picture? What is your observation related to gender, because that's our topic? Yeah.
A woman working as a caretaker and
Yeah.
helping other women.
Other woman. So there's no man in this picture, simple as that. No male in this picture. So what is happening is that this is showing that women are not being allowed, perhaps, in that society to consult male healthcare providers. Maybe that is the reason. Another thing that you are noticing is in their appearance, in their attire. Healthcare provider, an educated person, just we are guessing based on her role as a healthcare provider, her dressing, and then the woman who may or may not be educated, we don't know, her dressing in the same society, such a big contrast. She is not even allowing her face to come in the camera in the picture. These are all clues towards what is happening in that setting as a society, which can affect these gender inequalities. So Sohaib was a researcher long time ago. I am old. Just reminded me that it's getting, yeah.
That picture, the last page, it was Pakistan.
Yes, it was Pakistan. And these, I will now share with you these interview quotes. This was my doctorate interview, qualitative research, interview-based process. So I was the one who was asking questions, and not this slide. So I'm the one with the question Q, and then the respondent is with answer A. So in this particular piece of interview, I'm talking to a husband about her wife's healthcare practices. Where does your wife take treatment from? Earlier, there was a woman doctor coming from city every Sunday. She made clinic here, My wife was going there, but she stayed for just 2-3 months and moved. So I'm asking, and now, where does your wife go for treatment now? And the husband replies, she is fine nowadays. That's a strange answer. But if she gets ill, there's a woman in our village who treats women. She knows treatments. Is she qualified MD? In British system, it's MBBS. Doctor? Don't know, sir. Later found out to be a quack. So I'm asking now from a different angle. Do you allow your wife to go to male doctor? She has never been so ill that she has to be taken to a man doctor. But if needed, we shall see then. It's not a custom here. Women go to women doctors. It's the way it is. What do you think about it? I don't take my wife to man doctor. It's not good. If it is something very serious, they're fine. So totally pushing the whole issue under the carpet of women seeking health care if the same gender healthcare provider is not available. Now, these are the real life scenarios that are making those statistics happen the way they are in those big data. Yeah.
Was it impossible to ask the woman herself?
Let's see. I will come to that. What do you see in this picture? It is a vaccination process happening, polio vaccination. These are vaccinators and the kids are getting polio vaccine. What do you see?
The vaccinators are men and boys are getting vaccinated.
There is a girl also getting vaccine, but yes, the vaccinators are men. That's a valid observation. What else? Where are they located? Outside in the street. So what's really happening in our real life is that these vaccinators, they are going door to door to offer free vaccination delivered right at your door. What can be more easy than that for a parent to save their children from polio, deadly disease? So what happens is that they go knock at the door. So the women are the housewives, again connecting to that socioeconomic future role. Men are outside working. So if woman has permission from the husband, so she sends the children outside. So men are not allowed to come inside directly in front of the woman. So this whole process is happening here. But then the other side of all these vaccination and similar campaigns is the improvement of health education in that neighborhood, in that society. Their job is to give vaccine, but also to tell the parents, why are we giving this vaccine? Why it is needed? Why you have to believe in this vaccine? But because of this gender segregation of not interacting at all, poor guys are sitting on their feet in the street giving the vaccine, but unable to have any health education interaction with the community. They will go next year for another vaccine, and the health education level of that woman and that family will be the same like it was. No improvement. So we are doing the whole circle of campaigns, one after another, repeatedly, but the health education of the society is still staying where it was 10 years ago. That is how important it shows the role of these gender-related interactions is for any intervention which has a community outreach element. So, in some cases, I was allowed to talk to women, but not in all. So the number of interviews with men were much more than with women because of this permission issue. But here is an example of me talking to a housewife So I'm asking the question to housewife that whether she talks to the vaccinators who come to the door. Do you talk to them? No, I don't. Why you don't talk to them? Are these polio people polite? How they behave? I don't. I tell them to talk to my husband. Now, few more observations. Compared to my previous talk with the guy, here my questions are getting longer and her answers are very short. Again, a gender-related aspect. Here, even though I have been given permission, I know that it has limits. She is not saying much more than yes, no, basic stuff. And I know that this permission can be taken back anytime. I have to make the process quick. So I'm asking more and more in the same question. Eagerness, yes.
If you were a woman,
Yeah.
would you got a longer answer from?
That's my perception. That's my perception, and that's what we see in our real life, that it happens. I will explain one more thing to that in a minute. So now I talked to a guy, a wife, and now I'm talking to a vaccinator who is a guy. Is there any difference among men and women how they deal with Jew and the campaign? Men are often away in daytimes, so often women come on door. Or we send some neighbor kid inside, but they are often afraid of doing this vaccination without first talking to their husbands. And they know nothing about vaccines or polio. So we have to look for the husband or some other man in the family. Why do you think they behave like this? They are women, they don't know these things. How sexist of a sentence he has used, how rude phrase he has used. But still, they are women, they don't know these things. And what about men? Men know if they want their children to have this polio drops or not. We can talk to them. Yeah?
Excuse me, can I ask the question? And I'm interested about this situation, and if the men connect with the other societies and conduct how to wives and children, and if a husband dies, it's legalizable, and how can that wife live then after?
So husband, that's now again, these roles and these practices change from society to society. For example, in many areas of South Asia, let's say, including Pakistan, so women's status may decline if the husband dies. Women's status in the society may decline in some parts of, for example, South Asia, not all South Asia, if the husband dies. So woman is being represented by the husband, and her value is when he is a married woman. So her value goes down, social value goes down in many instances. And as you see here, another important thing they are pointing out is without first talking to their husbands, they don't have any say, or they have very limited say in making decision about whether the kids should take vaccine or not. So this is what was in the first slide, that their decision making about healthcare is also limited, and also about the preventive health services and all the related stuff. Yeah.
In that area, which women has the best life?
Educated woman. So if some family breaks this cycle of the traditional roles of the two genders, so if the woman, girl children are also given the same attention and education as the boys are in the family, and she is encouraged similarly to get to the employment opportunities and building a independent career. So that is the way out. But then that story has some other things attached to that also, not for today.
Without husband, could these women prevail?
Yes, prevailing is a very shady term in my opinion. Prevailing is one thing, but here we are talking about the social inequality. So then that area, they get affected even more and more. And their indicators of gender inequality will drop down even further. So it has.
So we are talking about North Pakistan, I mean?
These are the southern parts of Pakistan, some rural areas.
I mean, if there is it a better life for those women who live there with who are educated,
Yeah.
Part of a
Yeah.
educated family,
Yeah.
or those women has a better life who aren't educated, but they have a respectful, rich husband.
Yeah, of course, the social status of the family often overrules all these individual achievements of education and career. If the social status of the whole family, which means the husband's family, is very high in that society, then it often overrules the education of the woman, because it assigns the same social status to that woman as well. But definitely education and career upbrings the woman in the society, but to a certain limit.
So without respectful family background,
It gets difficult.
It's difficult even if the woman is very talented and very.
Yeah, there are
educated.
gonna be limitations.
Uh-huh.
There are gonna be limitations. So some of these features we saw in this interview example. Now, from another angle of healthcare services and these gender inequalities. Now, I have come across societies where, on one hand, women were supposed to go to women healthcare providers. So overall, healthcare access was being limited. But then the other side was that women to work was not being considered a good thing. So restricting the number of women healthcare professionals and then expecting the women in the population to go only to women healthcare professionals. Do you understand what I'm saying? So affecting the women's access to health from both sides. From the user side, by telling them you can't go to the doctor unless it's a female. But then when females want to be healthcare practitioners, that is also being limited. Girls should not get all this education. She should get married and go to the role of traditional housewife. So decreasing the availability of women health professionals. So in many rural areas, we see that men healthcare workers are much more in number than the women healthcare workers. And then women are expected to go to those limited women healthcare workers, making it double impact. Yeah?
I heard lots about the Pakistan Center from your conversational lectures, and when it came from, and it is from the ancient, from the religious, and why did rules come, and why is it represented men in because men and women have different roles in their life, and so
Yeah.
why do the people put the men in upper sides?
So there are many different explanations. One explanation is that the roles that you mentioned of men and women, they are defined differently. When the woman's role is defined as being of a housewife, and then men's role as the breadwinner, as the earner, this definition itself is the root cause of so many of this whole track of social inequalities among genders. So the definition of the roles is different in different parts of the world. When you hear in America, in Finland, that guy says that, wife, you cannot go or look for work, you only stay home. In general, in the society, we cannot even imagine that. So it's different in different societies. What is the definition of the role? Then the other side, other explanations are also existing. So remember in the very first, that intro section, I was talking about that assess is divided into three categories. The financial and physical assess that most people talk about. But then there is social assess that is connected to our theme of social epidemiology. So these scenarios that I am telling you today in these interviews, this is mostly connected to the social assess. Social assess means all those cultural facilitators or barriers that are connected, all those religious facilitators and barriers that are connected, they are affecting the social assess. So the health center is there in the next street. It is not expensive and the woman can afford it, the family can afford it. But just because she is not allowed to go there alone, that is the limiting factor to assess that facility.
Can I ask?
Yeah.
Yeah, I was wondering, in your interview, you had the man, the husband, who said that there was a woman doctor for a couple of months, but then she went away, and then the wife couldn't access anymore to the doctor services. So I was wondering, how does it even in this kind of conventional and restricted system, how does it come to that there is a woman doctor coming and giving services, and how does it end? So generally, why do they go? Is it like I'm sure it's not quite very easy for them to come to work in these rural areas.
Yeah.
So is it the social pressure that kind of makes them go away?
Usually what is happening in these scenarios is that number one, the availability of women healthcare workers from the same rural area is very limited, because they are not sending their girls to schools that often. They are not getting their girls to reach higher education to be doctors that often. So the local women healthcare practitioners are inadequate in numbers. So there is a gap. So to fill that gap, the health system, the ministry is picking somebody from the next city, for example, and bringing them and providing them job here. That now this lady doctor will come from this city and she will provide healthcare services here. But then again, in that city also, so she has reached to that level of being a medical doctor, but still it is not that she can travel that freely and frankly, even for work, especially if it is long distance. So the whole issue of woman independence is affecting her mobility also. So for her also, it is extra challenging to travel to come to this area for work on a daily basis. So from both angles, it is a very common scenario in many rural areas of Pakistan, for example, and many other conservative societies, that The women healthcare workers from other cities are appointed to rural area health centers, but then they stay only for shorter time. They and their families cannot manage all this traveling of the woman alone on a daily basis. So they prefer that it's someplace very close to the city where they feel more safe and protected in their opinions. So from all these different angles, the role of gender is being impacted. So it's not just one angle that I say that, oh, they don't give education to girls and that's it. No, it's much more than that. It's the mobility itself. It's the education also. It's the empowerment. It's all these different factors. You saw in the first slides about facts that in so many countries, girls do not even get inheritance. You are talking about these societies where girls are not even getting share from their own parents' assets. We are talking about these societies. In my previous life, I graduated from medical school, so technically I'm a medical doctor. I haven't practiced since I came to Kuopio. I don't like patients. I like healthy people. That was very against my profession, so I switched to healthy people like you guys. But when I was young doctor, so in those days, so I was working in both public sector and private sector. So one day I'm sitting in my private clinic, so there is no formal appointment system, so anybody can walk in as a patient and wait. If there is already somebody inside, then they wait, they just walk in. So one day, this lady walked in. She is wearing the same burqa that you saw in the picture, but the color was creamy off-white color, not this blue shade that you saw in the picture. So this is common in Pakistan and Afghanistan. This same burqa is very common. So she walked in and she had some guy with her. So this is my chair, and then there's a stool usually for patients closer to the doctor so we can examine her, and stool because you need to make them move sometimes to assess the part of the body that you need to examine or check or palpate or whatever. And then there is one or two extra chairs just for the sake. So the guy sat there and the lady is on the patient stool and I'm here. So lady is closest to me. And it seems that she is the patient. So I asked her, okay, so what's the issue? How may I help you? So first thing I noticed was there was this burqa. I didn't feel that eye contact feeling that you kind of expect, when you are talking to somebody. Now the next step. So when I asked this basic question, so she listened, and then instead of replying to me, she nudged closer towards the guy that she came with, and he put his ear and she told him. And then he said it to me, even though we talk the same language. It's not that there's a language issue, and I was not wearing these kind of silly clothes. I was much more with tie and decent looking. So it wasn't like I was scaring her off or anything, but she still talked to the guy. And the guy said, she has pain in her stomach. I'm like, okay. So now the same process that I was doing with all other patients of directly communicating and examining the patient suddenly became few steps complicated. So now I said, my eyes went to both when asking, so which part of abdomen? On the right side, again, the communication happened. So few questions, and then I needed to examine that area by palpating. On the right side, we know there is appendix, which is very common. Appendicitis is very common, but then this appendicitis pain often starts a bit higher, sometimes even towards the center, and then it moves to that lower right side of the abdomen. but also based on the history, if patient has kidney stones history or some kidney issues, there is a kidney on the right side, there is the whole liver and gallbladder, so you need to examine these things. Can be something with the colon. So, and I was young and inexperienced as a doctor. It was just my first few months after graduating. So now the dilemma for me was that this awkward communication that is happening, in this communication style, can I expect that they will let me touch the abdomen of the lady? I did not know what to do. So I hesitated and I prescribed directly something very general based on the verbal explanation of the symptoms. And I advised her to go to that other doctor, some lady doctor that I knew in the neighborhood. I sent her there so that she gets better treatment from there instead of me panicking and not doing proper examination or getting hit by the male accompanying that why I'm touching the abdomen of his lady. So this is how the real life scenarios still exist that complicate this whole healthcare assess. So that is why that picture that you saw, that solves all these issues. And that was one of my recommendations based on my doctorate research, that more female vaccinators should be hired instead of trying to convince the society to let women talk to the male vaccinators. It's not going to happen that soon. The more practical is that if you simply hire more women vaccinator, first of all, this will hopefully introduce more women employment opportunities, and then it will hopefully overcome the flow of health education, and then it will overflow, or make the ease of the process itself happen better. And lately they are doing that. They have hired women vaccinators, and they have hired much more lady health workers covering the reproductive areas where women again find it very difficult to go to male healthcare workers. So for those reproductive health issues also, so more and more women are being applied by the health sector in Pakistan and other countries to overcome these gender gaps. I was taking a lecture of the medical students here at UEF, and they are usually much more curious than you guys, because some of you are also from similar areas to Pakistan, maybe some of you have like this kind of general knowledge or experiences, but I noticed that when it is a class with pure Finnish students, they are much more curious. I'm a bit more exotic to them than I am to you. So one guy, so he asked a question, and he said that tomorrow means in coming years, when the Finnish guy will be acting as a doctor in, for example, chaos, and the appointment, the patient comes, and she is that black wheel-covered, burqa-clad woman head to toe. So how should he behave? And that brought all this, my own experiences out, that I told him that based on these experiences now, how will you proceed with that? So one main advice among others was that the man accompanying that woman should not be totally ignored, because he is there because of their cultural reason. And if you totally not let him even come in and totally ignore him, not let him talk, so even that will mess up the whole process. Because maybe women do not feel comfortable talking directly to you. Maybe she is so used to and she is supposed to talk through the family man. So you cannot just assume that you will apply the practice of bypassing these gender segregation practices just because you are in Finland, so you will assume some certain way, but you have to like take their cue, take their lead. And then slowly, when you get the trust of the patient, confidence of the patient, then you can introduce this change and bring them closer and out of these gender contrasting practices. So slow change is more ideal. So this is what I told you this experience about. Now, I went through that medical school. I never found anything in my textbooks about transgenders people or any other gender people. I never found anything regarding to that in my medical school textbooks. So someday, if people from that gender show up as patient, I will not be a good doctor. So I mean people similar to me who are going through these medical books without enough descriptions, without enough research and knowledge and data about these other genders. So they are hugely underrepresented. They are not considered the norm. And this does not just limit itself to the genders. This also goes to ethnicities, color of the skin. Africans, Black people, they are also very underrepresented in these medical textbooks. So most of these medical textbooks are about white males. Of course, we have differences in our anatomy, in our physiology, based on ethnicities, in our genders, obviously, but they are not considered the norm, the standard, and they are teaching us the standard. And maybe that we are supposed to adjust to the not standard with our own experiences. That is probably the assumption. So your job and our next generations will hopefully be working on producing evidence equally about different genders. So as Michael Mermert says, fairness in all policies. So gender should be included in all health-related policies, and health should be included in all policies. So I would highly recommend you to just go to YouTube. That's the easiest way of learning, I have noticed, for the students. No reading, no textbooks, no articles, but simply go put his name on YouTube, and there is loads of videos of his interviews, his speeches, his presentations. So he is a very, very charismatic presenter as well. So he presents and makes things simpler, in my opinion. So I recommend that if you are to follow this field, so do regularly check out his work. Now, before I end, so in addition to all these general different aspects of gender inequalities, we are seeing this very current COVID pandemic has also brought up many unique aspects of gender inequalities. It has affected women differently than it has affected men. Can you make guess how? Yeah?
Been leaving the workplace in, I think it's like double or triple to men?
Women are leaving the workplaces double or triple compared to men. Why is that? It's true, I agree, but why is that?
At least in my experience, those I know who have left is because they're working mothers.
They are working
and
mothers.
They couldn't care for their children and
Yeah.
work a job.
On one side, in certain professions, the workload demand suddenly increased. Most of the nursing staff, for example, that are the immediate caretakers for these COVID workload, so they suddenly have to have much more work hours. And then in their role as mothers, so this was not manageable, this increased workload.
Yes, and having the children do school from home while
Yeah.
the mother is also working from home.
As we notice even in the Finland statistics, women were giving much more time, more than an hour time daily compared to the male in house chores or chores, how do you pronounce that? So that includes this taking care of the kids. And kids aren't permanently at home because of schools getting closed by COVID. So she is supposed to have much more workload on home front as well. So now she suddenly has increased demands from both work and home front. So that's why she was quitting much more, showing, of course, mother's tendency to prefer the children over job. Other aspect is the risk of these first responders to themselves get infected. So they have families, so they are not gonna be a vessel to transport the infection back to the kids. That was also one reason for many nurses to quit. The fear of exposing their own families to the virus. Yes, you were saying something.
Yeah, I would like to say the same.
What else? How else women are more affected compared to men because of COVID-19 crisis?
It is connected to the education and also more about Mongolia, more women are more educated and comparing to men, and so it's the one reason. I think.
I didn't get exactly what you are saying, but that is the point. Keep thinking about how. How about the domestic environment? Mental health issues increasing because of COVID crisis, all these fears, losing jobs, increasing poverty, stress, health issues themselves, causing extra anxieties and depressions. How about domestic violence? It has already been reported much higher in many societies compared to pre-COVID days, and women are usually the victims of this domestic violence. What else?
What about Mongolia? Most of the men went to the Korea, and so what about the gender and women are going to and the main roles in the Mongolian society, and so I think it's the indication of the one of thing in last 2 years. We had COVID-19, so it's commonly increased that anxiety and psychology indications for all things, but it's different from Mongolia, in my opinion, because because Mongolians live together most of the occasions, and it's different from the, I think, in Finnish culture, maybe other European cultures, it's different, I think. And so I think anxiety and psychology problems is more or less than other countries, in my opinion. I'm not sure, and I think because our traditions and Russian cultures is different from European and other cultures, it's different.
Good to know about this unique element from the Mongolian society side. And I'm sure that all of our home countries and home societies, these information that I'm sharing is not going to be 100% matching, but our job is to start thinking and seeing how things are. Of course, it does not mean that all those very severe social and cultural and religious barriers that I mentioned, for example, from some parts of Pakistan are going to be replicated and translated similarly in your societies, but degrees can be different. Okay. So what we will do is that I will bring your attention to these areas. So United Nations identified these areas where COVID-19 has an impact connected to gender. So gender-based violence, including domestic violence, increased. So the goal for United Nations Women Response was to mitigate and reduce that. The social protection and economic stimulus packages. So economy got affected in general, but then it was noticed that the economy indicators for women were affected much more than that of men. Support structures, equal sharing of the care work. So this was not practiced. So women healthcare workers got much higher load compared to men. And then the data and coordination mechanisms should include gender perspectives as well. So these are the key areas of response of United Nations to address these gender inequalities in the effect of COVID. That their economy got affected worse than the men. Their jobs were mostly those that are first responders of the COVID. Their social support structures got affected. Their workload, work environments got affected. Their home workload got affected. So they got affected from all these different angles, and then additional component of the domestic and general violence issue against women. So I'm putting this link here in the chat. So team people should take a look at it. It's just 2 minutes link, and we in the class are gonna listen to it. Is that okay with the team's people? So you watch this YouTube video, and we are gonna watch it from our side in the classroom. So the same points that we just discussed on our own, so the same points United Nations have also reached based on their reports. But then there is this detailed link. If you want to go into detail, then please follow this link and it will have much more information specifically from this point of view. So based on these impacts, the response is focused on these areas specifically. But again, different countries are dealing with it differently. In most part of the world, it is not even a point of attention. Most countries are not even thinking about discussing the difference in genders and the impacts on differently on genders because of COVID. Most people are simply at the very basic needs of vaccine supply, for example, or improved testing needed. They are not even reached beyond those basic needs to consider something like a discussion about genders. But in countries like Finland, for example, the rest of Scandinavia and some countries from Central Europe, perhaps Canada. So this gender debate is mostly coming or starting from those areas. So if you are from Mongolia, if you are from Nepal, India, Poland, so take a look at your own countries and see what is happening on the ground, how it is different from those countries that are reported to be doing better in the rankings like Finland. Where are the differences? Are they simply in the women reproductive health indicators? Are they simply in the differences in the empowerment based indicators? Are there differences in the labor market based indicators? So which of those three themes where the women are losing more out compared to Finland, for example? Make sense? So now that is my introduction to you from the angle of genders. Some things were very much theory and data, but then I tried to present to you some real life scenarios as well. So you get to develop this habit of thinking about the real life reasoning behind these things. We should not be just lost in these data. Data are there to guide us. So we should not be totally lost in that. We should remember that our purpose is to go forward from that data and see that how we reach the designing of an intervention stage. That is our ultimate goal. So just understanding the data that Finland is doing better than Afghanistan is not going to give us much. But to understand in detail that which indicators are performing better or worse and why. And whenever there is this question of why, we have to go to the ground. We do not know the answer to why in classrooms and in conferences or in textbooks. For that, we have to look at the real life scenarios in the society. I thank you all for joining today, and what we will do is that I will be seeing you again for this interactive sessions, 2 sessions on the same day coming up. I think it 8th, it's Friday, I think. So there, I will ask you also to share more about the gender and then these other aspects of social epidemiology that we have been hearing in the lectures. There will be still coming a lecture about social epigenetics. I think it's tomorrow. There is a lecture about the healthcare inequalities. And then there will be a lecture later about migration and health. So these 3 lectures are still to come, 2 discussion sessions, and then finally that presentation group work. Any questions or comments from your side? Yeah.
I want to appreciate your lecture, and it was very interesting. Thank you for case, because students don't forget the cases and teachers and lectures cases, and it was interesting And I want to appreciate that culture and yeah.
Thank you very much. Thank you very much. My response to that is that I have never been good with numbers. Even when I was a student, now in my post-student days, I was never good at numbers, and I was not that interested in numbers too. So I always use data to get a cue from. But then my personal interest is always to get to the what is happening on the ground, on the field. So because I think that most answers for science and especially health sciences are there at the ground level. So use these data to get a cue, but then move to the actual world, not classroom-based theories. They are just a starting point. So I hope that this makes you think about your societies little bit in a more focused way about gender roles that you may come across as some new things that you notice in the society. And this is a very interesting field in research also. So there has been both quantitative and qualitative methodologies. Both have been used to explore these social epidemiology issues and then gender inequality issues. If you spend some time on PubMed, for example, and see from this gender and social epidemiology, you will find lots of interesting articles, and some will be sharing these ground realities. It's very interesting. Thank you. Yes, our Hungarian friend.
Could you please go back for that slide? It's pink slide. That's one.
This is Finnish data. This is Finland
yes,
data.
Yes, of course. My question, well, it would need a long answer. So we have no time much. Well, my question is partly philosophical, partly pragmatic about that. But what numbers actually are behind this presentation? In another way, what would be the ideal in every? It's 9 slides in one slide.
Ideal is equality. That's the
I don't
ideal.
think so. I don't think so, and that's why I told it's a more like a moralic and a philosophical question, because equality is it's kind of impossible. So, for example, girls and boys, the life expectancy at birth, we want an equal number. It's 40.
Why is the life expectancy for men and women different? What can be the reason?
It's biology about.
There's no other reason?
There is other reason as well.
Social reasons. What can be the social reasons?
Women are most likely to rethink every action they take, and
Okay.
men are more like, you can call it bravery.
Okay.
It's like not thinking about all of the actions and the consequences. So maybe that's the more.
That can be one reason.
So
True.
I don't hear you absolutely nothing.
Okay, so should I repeat?
Come here. Come here. We want to have you here.
So maybe it's probably because women tend to think more about their actions and consequences, because you can see all over the internet that the most like stupid actions are mainly caused by males, and the same goes for the car accidents or all of the most dangerous activities are.
Let me sugarcoat it, what you are saying. Sugar-coated version of what our friend is saying is that the lifestyle choices are different between men and women. Men tend to have a bit more non-healthy life choices, lifestyle choices compared to women.
Yes.
Is that true?
Yes.
And that stretches from every aspect of life, including all these things that you mentioned, that men are more prone to do stupid stuff, let's say. So I agree with that, that our style is different. Our lifestyle choices is different. So I 100% agree with you. What else?
And I have read the articles, like the report last night that Professor UC has asked us to read, that there are the smoking, the prevalence of the smoking and the prevalence of consuming alcohol is more widely prominent in men than in the women.
True.
So they are, what?
Yes, very true. So again, our choice of lifestyle, including these that are directly connected to health, like smoking and consumption of alcohol, better on the woman's side generally than the men. And then also the other kind of lifestyle choices, more rash driving, more traffic accidents, more rash dietary habits. So all those things definitely, yeah.
And in one report, I have also read that the consumption of fat that leads to the serious disorders is more prevalent in men than in the women.
True.
So
True.
they are more prone to die of heart attacks and myocardial infarction and the problems
True.
of the hypertension related disorders. So this might be a reason as well.
Yeah, so more high risk practices in their choices across the different life settings, whether it is diet or whether it is some other aspects of lifestyle like smoking and alcohol, and also the sport activities. And
yeah, I was just saying that, like you said, lifestyle choices, but I think
Yeah.
they're like part of the culture,
yeah,
part of the same culture which
Yeah.
oppresses women.
Yeah.
It makes
a certain
men
type.
do stupid things.
Yeah, it is definitely has roots in the culture which expects women to not behave in those rash activities that the society ignores when men do it, or even expects men to do it. How about occupation? Have you thought about difference between men and women in occupations? Don't you see that they are so different? Men are
Yeah,
on these high
women
risk
are working
occupations, much more
in a
physical occupations, much more high risk occupations. In Ukraine, so many men are dying. They immediately ordered that all the men from 18 to 50 years old should stay behind.
But this slide is not about Ukraine.
Yeah.
So let's talk about this.
So here again, the story starts from the definition of the role of genders in that particular society. And then comes what is ideal or not ideal. So in this society, the definition of the role of genders, for example, in occupation is that both genders choose whatever they want to do. And there should be no limitation if a girl wants to pursue a certain occupation and if she is qualified for that. If there's no limitation, then this should be perfectly equal, the occupation types. But that is ideal. But now compare it to Afghanistan, and there women are not supposed to choose certain occupations, and similarly men are not supposed to choose certain occupations. So then the exact 100% equality concept is ideal, like you were originally saying. That no, it's not true, because first we need to define clearly the roles of genders in that particular society. Only then we can decide what is ideal and not ideal. So in Afghanistan, it is ideal if, according to Taliban, if all the girls and women stay inside the house and do houseworks and raise the next generation and cook and clean. And then, according to that Taliban rule, it is totally ideal that in men in the same society of Afghanistan, they all should get out of the house, go find a job, earn, come back, eat the cooked food, and then make decisions about all the aspects of life of that family, including the health. So there, the definition of ideal is different than our definition of ideal. So that's the trick, that there is no ideal which we can expand to the whole world. So it's difficult to answer, but this is among the best statistics that a country, a society has achieved in 2020. So no society has reached the so-called ideal level. Yeah.
I think that we should make a difference between if a rate at the comparison, for example, to genders, if the numbers are gives an acceptable difference or not. So women among elected MPs is 47%. It's quite equal. It's quite 50%. My ask is that an acceptable difference or not? And that is my question in every slide in this 9 slide.
Acceptable is different for different people. For this society, acceptable may be that society wanted more women in the parliament. Maybe, just giving us a scenario.
Yes, but is there a rate with sense?
We cannot decide a rate.
Why should it be acceptable that there are differences?
Sorry?
Why should it be acceptable that there are differences? Why should it be okay that there are differences between men and women? I mean, you're asking for a range like minus 5%, plus 5%. This is okay, but why?
Again, it's about the society. For that society and its customs and concepts and traditions, some society may find this actually against men, even though men still have 3% more representation in the parliament. But some society, a Pakistani may say that this is against men. So again, it comes back to how that society norms are. So we cannot disconnect the gender norms from where that society norms are. So it has to be seen together in the same context. So Finnish statistics are gonna be interpreted differently by a Pakistani, and it is gonna be interpreted differently by a Finnish person. Do you understand what I see? Even though in numbers it is showing that, for example, men are doing much better than women in earning per unit. But if a Pakistani from a rural area sees that, oh, in my country, women are not even supposed to work, and here they are not only working, but they are getting almost the same pay, almost. They are happy with that. So the definition of and the acceptance changes from society to society. Yes?
I agree that conditions about the gender equalities, and can I tell funny comments, because my students ask from me, what is the difference between men and women? And they are asking about, because most of the students are girls, and they ask, why do we more better than boys? And they ask, and I answer them, because you have 40% of the structure you have fat, and men had 40% you have muscle, and so boys can't get fat. Then it's related to the structure.
This is one explanation. So the story starts, the reasoning starts from genetics. There are genetical stuff that is different, that makes us, our biology and physiology and all that different. And then the third side is the lifestyle choices. And here the society has influenced. What lifestyle choices men and women go for is under the influence of social setup. But of course, when somebody is an exception and he chooses to go not following the societal norms, but makes his or her own way, so he or she can break these indicators and come up with a different contribution to these indicators. So differences do exist. So we cannot say, in my opinion, that men and women are the same. But unfortunately, the term equal is being confused by same. Same, we are not. We are different genetically, biologically, physiologically, socially. But equal means something different, that our opportunities should be equal. Our decision-making right should be there. We should be equally empowered. So those things should be equal. But often in societies, this difference between the concept same is so unacceptable that they also end up affecting the equality. So these are different directions, different concepts. We are not same, but we should be equal. We deserve to be equal. Let's continue this discussion in that interactive session. So we will include these points to further hear from you. Any final question or comment from the team's friends? Did it make you think about your societies? Anybody listening to me?
Yes.
Yes.
Yeah.
Okay. Okay, so let's continue these thoughts, and then we will talk more about these issues and much more in that interactive session. Thank you very much, everybody, for joining and being patient with me. Thank you.
Thank you.
No,